Hey, welcome back, everybody. It's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. I got my usual podcast proximity associate in Caleb Ferroni here. Two special guests. We've got completely across from me here, we got Dr. Frank Forde, who is EM doc, as well as one of our EMS medical directors for the UH system, and Dr. Colin McCloskey, who is also a EM doc, as well as anesthesia critical care. Guys, welcome. We have a I'm actually excited to do this. I've been looking forward to this all week, and we're doing a ECPR or ECMO CPR talk today. And this is something that in the greater Cleveland area currently only UH is doing. And as of recently, in the last week, talks have been going on that we're going to add other centers, including, it sounds like, to absolutely include the Cleveland Clinic to do this ECMO CPR. And I guess first and foremost, let's for the audience, we want to talk a little bit about what ECMO is, and then really what we want to drill down to once we get the nuts and bolts of the procedure, how it's going to play out, is then, of course, where does EMS tie into this, right? So sure. We'll get to that in a little bit, but for the audience that maybe has no exposure on the hospital side of things, more familiar with it, the critical care transport side of things, we're very familiar with it, but who wants to take a stab at what ECMO is fundamentally for somebody who's maybe heard about it and just really hasn't taken time to study up on it and understand what it is?
All right, I'll take it.
Yeah, sure.
So ECMO is that's short for extracorporeal membrane oxygenation. Basically, it is a heart-lung machine. A ECMO circuit involves really three components. You have cannulas. These are anywhere from, in VA ECMO, you'll have an arterial cannula, which will be like 17 French. Yeah. That's pretty big.
Yeah, big hose.
For venous will be anywhere from 25 to 29 French for like a return cannula or drainage, depending. You have that. You have the connection tubing. That goes to a pump. These are all impeller centrifugal flow pumps. It then pipes it through a membrane oxygenator. This is where blood goes against a bunch of fibers that have fresh gas. And that's where oxygenation happens. That's where decarboxylation or CO2 removal happens. That blood is then returned to the patient and is supporting either in VV ECMO, just the lungs, or in VA ECMO, both the lungs and the failing heart.
And what's that VA, VV breakdown?
The V and V is, the first letter is where we're draining blood from.
So venous, yeah.
Venous. Yeah. Generally, it's always, there's no such, like, AV ECMO doesn't exist. It's always going to be a V. And then the second is where we're returning it. Yeah. Right. So in VV ECMO, we're going to return it back to the venous side. So that's dependent on having a right heart and then a left heart that works. Okay. So we use that predominantly for respiratory failures. Okay. And then VA ECMO, you're returning it to an artery. Most commonly in ECPR, it's going to be the femoral artery, so you're going to have some retrograde flow.
I was going to ask that a little bit later.
And you can, any artery that exists, any vein that exists that's large enough, you can do these configurations. So you can get a little bit wild in the congenital population and a variety of like post-cardiac surgery ones. But for our purposes here, usually we're talking about femoral, veno-arterial ECMO. We're draining from the SVC RA junction, so a pretty long venous cannula, out the femoral vein to the pump, the oxygenator, returning through the femoral artery, which is shorter, kind of ends in the iliac, then retrograde, hopefully to the brain and to the coronary arteries.
The rest of your arteries, yeah.
That's right.
Sure. So that's essentially a bypass pump.
That's the history. It grew out of cardiopulmonary bypass. Yeah. There are a bunch of differences. You can do higher flows with these pumps than you can with a coronary cardiopulmonary bypass, and there is less of a air-blood interface, which reduces the inflammation and some of the complications of that bypass circuit.
Sure. One of the amazing things to me is that this is not a new subject. When I was looking into this before the podcast, I saw that the first successful case was 1929 on a canine. This is not new by any means, and that to me obviously was VV, but that's amazing. we're just hearing about it. Well, I'm just hearing about it, in the last couple of years that we're doing this, Cleveland's doing this, and that's really cool.
Yeah, the history of it's fascinating. Once again, it did come out of the cardiac surgery operating room. First clinical uses in the 1960s. First use in the ICU was actually on like a trauma patient with pulmonary contusions in the 70s. And then the technology and some of the like research and evidentiary base really didn't, it kind of stagnated for a little bit. There was a big pickup in the neonatal world in the 80s and 90s when Dr. Bartlett in the University of Michigan was using it for congenital diaphragmatic hernias and aspiration, but it didn't really take off in the adult population until like H1N1 in 2009, 2010.
A lot of pulmonary diseases.
Yeah, so you had young, healthy people getting a really inflammatory pulmonary disease who really just needed time not to die from their, viral pneumonia. So you saw a lot of, there was also technological revolutions that happened earlier that made a lot of the prohibitive natures of like how complex the technology was. The technology got, by getting more complex, more simple to use and far more reliable. And so you had a lot of centers have a lot of wins. Young people that were dead, walking out of the hospital with pretty low levels of morbidity and then a ton of just experience. And then they're like, well, what can we use this with?
Right.
And then it's been expanded to include cardiovascular then, which is amazing.
Right. Well, once again, the machine and the tubing and the cannulas are all the same. It's just what are we cannulating? Right. And this has been used in, as an extension of cardiopulmonary bypass for, decades. So now it's what are the other uses that we can use this outside of the cardiac operating theater?
Yeah, I think I've seen it, even during COVID times too, was similarly used for like lung bypass for those like extremely hypoxic patients. But, like Colin was saying, I think as we've gotten closer to like modern times, it's really also improving the logistics and like how you can actually use this for patients who have less time, right? Who are like more unstable, and even like we're going to talk about actually in cardiac arrest.
In cardiac arrest, how much more unstable can you get?
Right? Because in the past, it would patients who were stable and had time, right? And you could get all those processes in place and get them on this pump, right? But that's going to take hours, maybe a long transfer to get there, right? And like then more recently, probably in the last, I don't know when Europe started doing it, but talk about that in the last couple decades of really, how do we do this emergently for a patient, right? Mm-hmm. It's a whole different ballgame.
Yeah, I mean, in my 28 years, I can remember when, it was almost unheard of to certainly have an ECMO case anywhere around, and then to transport them was like, we trained for it and practiced for it, but it was like so prohibitively difficult to do. Now it's literally a phone call. You get a phone call, team gets on, and hours later they're in a truck moving back to Cleveland Medical Center or whatever center we're taking them to. It's that technology is like you said, has really improved. Stuff's been miniaturized and it used to be an entire truck, and now guy walks out with a bag and a pump and hops in the car and be like, let's go to work. It's really evolved. So let's direct this a little bit to what we're specifically here for, which is the ECPR. So how does ECMO and CPR, what's the overlap here, and ultimately where does EMS fit into this? But what's the ECMO and the CPR overlap?
So these are going to be specific. So all ECMO is time with a price. That's actually all of intensive care medicine is really time with a price. But ECMO is even more of that to the extreme. So you want to take patients that have the highest possibility of having a good neurologic outcome in the context of cardiac arrest and bridge them to, a therapy or give them time for their pathology to resolve itself. Right. So when we specifically are talking about ECPR, we're talking about cardiac, we're talking about acute coronary syndromes that are causing a VT arrest that have all the favorable time characteristics. Witnessed arrest, really limited low flow or limited CPR time. You get them on pump and then they get their cath. or, some of the other ones that have been used, PE, then they get their thrombectomy. Or if it's a, cardiac intoxication, they just have time for 5 half-lives, and then their heart starts up. So it's really the application of, for EMS, like how do you find these patients and get them to either get them to the hospital or get them to the practitioner to put them on pump. And then what does that look like? How do you train? How do you do it? And then what is the post-arrest care take look?
Who on your team is sitting there to make the decision to say that they are meeting criteria, that this is actually a shot? I mean, because obviously if there's no hope in reviving an organ that's not working, you're not going to use these as candidates, right? So obviously you have criteria, and then I would assume a few of you make that decision to say, let's go ahead with this or not.
Yeah, I think you talk about the field criteria first,
Sure.
comparatively.
Yeah, and so, and kind of like what Colin was saying too, like how I kind of explain it, when I teach my crews and things, it's like we're trying to identify those cardiac arrest patients that are likely to have some fixable cardiac
most
problem,
salvageable,
right? And you're putting them on ECMO to perfuse their organs to get them to a cath lab when normally they're not going to get a cath lab unless you get a pulse, right? And so from the EMS perspective, a lot of it is operational, right? Identifying the right patients, moving your care along where maybe we're not going to stay and play like we normally do, right? Because we need to mobilize. Time still matters, right? And then also getting them to the right place and getting those downstream operations activated, right? So similarly, like if you have a STEMI patient, right? You're going to call that STEMI to wherever your receiving facility as soon as possible, right? Because everyone's coming from home often to get to the cath lab, okay? And especially any providers out there that go directly to a cath lab and bypass the ED, you never want to get there before anybody else does, right? But that happens. And so really what we have taught is field criteria to really make it as simple as possible to, find these patients. And then when they are calling in, like we normally have, they're going through an ED quarterback, right, who just like they would have the trauma criteria in front of them, right, or they can page out a stroke or a STEMI, they also have this criteria in front of them and can review it and page it right from there as well. And then if you want to know like the rest of the process is, so that gets paged out, that page goes to several people in our institution, this is down at Cleveland Medical Center, that page goes out to the cardiac surgeon, right, who'd be cannulator, goes to the cardiac ICU staff, the interventional cardiologist, the person who would actually take them to the cath lab afterwards, the perfusionist, and then also like the ED people, and there's probably some others I'm missing as well.
There's like nursing supervisors, there's
like a lot of other people,
to make the beds happen.
Right.
Everyone who needs to know gets.
And then the criteria that they're making, because if we're here in Munson or Chardon, Ohio, I mean, we're not going to be driving these patients to you. I mean, I would have to imagine that time is part of that.
Absolutely,
distance.
Yeah, and right now, like what we've said initially is usually a 30-minute or so radius, right? Because we want to try to get them, and he knows more definitely about like the data behind some of those numbers, but time is important, right? And so a lot of it is trying to get them to the right place, so that limits your catchment area. But also there are, and we talk about other systems, there are other systems where they have several different hospitals like within the region that could put them on the pump and then transport them afterwards also. And so there's a lot of different systems out there to try to really increase that catchment area, to increase the amount of people that we can get this, therapy to.
I'd like you to focus a little bit on that difference between our traditional teachings for the refractory, or just VT patient, working them on scene, versus what we need to, you said that this is really an operational change for EMS. It's really not a clinical change, but you just kind of contrast those two things for us.
Right, and I think even in my years in EMS, and I'm sure you guys can test this too, we go through kind of cyclical changes sometimes, right? Like I think in the past it was like sick patient, get them to the hospital as soon as possible, right? And then we kind of get into that other phase where we're like, wait a second, we can do CPR, we can do airways, we have epi, we have all the therapies, we have everything that they have, right? And so now that we kind of have this new therapy for these patients, if what you're doing is not working, we need to get them there, right? But if we're waiting for 3 shocks, 4 shocks, you're already 20, 25 minutes down the line, right? And then you introduce a transport time on top of that, extrication time, right? If anyone's been in some of these in some of our areas around Cleveland, maybe it's an old apartment building or something, and the elevator's small, and you gotta go down the stairs.
Steps or
Every
whatever.
step is more time, right? And so what we're really trying to do is identify these patients early. If your initial round of therapy, you're shocking them, you're doing epi, you're doing amnio, your initial isn't working, they're still in a shockable rhythm. Change your mindset already and start, packaging and getting ready to go to the hospital.
If you're within that 30-minute transports.
Yeah, and I think it'd be
sphere
safe
from
to say
CMC.
that any protocol listeners there, that if this was available to you, you would know that. I think you would have had training with them, and so I don't think anybody just listening like, hey, I can make it there in 30 minutes. You're probably not part of this, right?
No, and right now it's these squads right around our area at Cleveland Medical Center for now. I would say, both of us can agree, like there's no processes in place elsewhere, but looking into the future, I think this is something that will expand to other hospitals.
Part of why we're doing this.
Yeah, right. And we educate our squads a lot on that, to really have that mindset to be able to flip, because it's really hard when you're in the moment to think about it, right? Unless you learn about it and think about it quite frequently ahead of time.
Yeah, absolutely. And
I think the key time for people to consider is 1 hour of low flow time, right? You have your arrest. Ideally, it's witnessed. Ideally, there's bystander CPR.
Yep.
And then we really we know from the data that the inflection point for where having good neuro outcome, because that's why we're doing this. We're not like, we can put corpses on pump. But the point is, can they walk out of the hospital? Right. And we know at about 60 minutes, we're now, the chance of that, is approaching that of conventional CPR. So why go through the cost, the training, all of, the iatrogenesis of an ECMO run if we don't want to do that? Now, that is kind of, that's in paradigm 1 of eCPR. We have the 60 minutes. Can we expand that out now that we have some of the stuff coming out of Europe with controlled reperfusion of blood and all, we'll see, right? But I think 60 minutes, that 1 hour is, that's what we use in our program. That's what most programs are using. Outside of hypothermics, we're not talking about those. That might come up later. There are some
outliers, yeah.
There are some outliers where it absolutely indicated. But for our out of hospital cardiac arrest, normothermic, shockable rhythms, time from arrest to pump, if you're under 60 minutes, you're going to do pretty well with those patients. And, we wanted a 30-minute transport time, meaning it's within 30 minutes of the hospital. Because we can put you on pump in probably between 10 and 15 minutes. Some systems are even faster. The folks in Minneapolis, they do it in the cath lab. There's videos of them doing it in 6 minutes, which is awesome. I mean, they're fluoro, they're interventional cardiologists, their skill set is amazing. Us in the ED, cardiothoracic surgeons, also excellent, proceduralists, where our cannulation time is 12 to 13 minutes, which is good, which allows us, if you get us, get to the hospital from time of arrest at about 40 minutes, we're going to be able to do the things and get them on pump before that time.
Stay within that window.
Yeah.
A lot of that depends on, though, that early activation, early identification, right? Because some of that time is also just the important people, like the cannulators, getting there, right, and initiating.
And how many ECMO cases can you handle at once?
So is that a question how many physical pumps we have and beds we have available? So generally and this will be changing, obviously, if we expand to multi-institutions, because then we're drawing on more resources. But right now, and we know this from COVID, we probably can support physically with machinery about 12 patients. With nursing and bed availability, that number is really halved. Yeah. It's 5 or 6. Yeah. And eCPR is, we'll talk about the epidemiology. It's fairly rare, even in a system that's been doing it for 3 years. But we also have people on ECMO from our shock programs, from VV that is not eCPR, post-cardiac surgery. So we have, we do about 90 to 100 ECMO runs a year, probably for true eCPR that we're talking about here out of hospital. It's 4 or 5. So we're talking about 5% of our ECMO. So it's not we have 5 beds for eCPR waiting. We probably have a couple circuits available and we can take it.
And it would be probably safe to say that the outcome isn't always 100%. So when you have people who come in and you give the family, as a patient advocate, hope that, hey, we're going to try this ECMO, and what are you telling them?
So if you look at, I can tell you what our experience is, and I can tell you what the kind of the international experience is. For folks with shockable rhythms that get to the hospital, you're looking at a 10% chance of having a good neuro outcome, 1 in 10. All right. For most systems, and this is most published data, which probably has a positive publication bias, so this is probably overstated.
Yep.
It's about 30% for ECPR. Because there's probably a selection bias there. We're putting people on that we think are going to do well.
Of course.
We have had small numbers. We've had 12 people cannulated. 7 of them have walked out of the hospital. So that's north of 50%.
That is.
And Minneapolis, which has the largest domestic program that we have here, it's just, it decrements with time. They have if they're on pump within 30 minutes, it's like a 70-something%.
Wow.
45 is like 50.
Huge.
Then it's 60,
Wow.
at about 1 minute, about 1 hour, it's about, 35. And they've even gone out a little bit farther. And
which is still amazing to me.
I take a 30% chance.
And
revolutionary change.
And when
right.
we're talking about versus 10%.
Yeah.
Right?
Yeah.
And within the bounds of the people we're talking about, these are generally young folks that have, good things, so that there's, you can make arguments for quality adjusted life years. You're doing work here. There is a benefit.
As far as the EMS side of things, have you found it difficult to try to rewrite paramedics' brains to think that if there is a ECMO case that they do need to pick up and leave now? I mean, you've kind of talked to it, but are you finding that you're getting any pushback?
Not too much pushback. I think it's hard to remember it as top of mind, when you're in a cardiac arrest, especially a shockable cardiac arrest, right? There's a lot of things that you're thinking of doing, right? Medications,
going on, yeah.
You're charging your monitor or making sure all your timing is good, right? And so just some I've had definitely squads that know it, and then they just don't think about it till they call in, right? And so that's kind of the biggest change. Once, everybody that I've done education and kind of showed them numbers like this and just the process, people are really interested. This is revolutionary medicine, really modern things that you see the numbers difference, right? There's a huge mortality benefit for these patients. I think everybody's on board. They really are. It's just more about trying to rewire that they're thinking of this is part of your, could be your standard therapy, and probably is standard therapy now for refractory shockable rhythms, right? If available. And so just trying to it's more the education piece. And so we've done a lot, where I do a lot of refresher education. We have a lot of these kind of quick 1-page kind of printouts of criteria and everything in the firehouses. We've done we thought about making stickers and putting them on the Lucas and things like that, so you're just looking at it right when you put the Lucas on, and just trying to remind them, right? Because that's the most difficult thing.
Yeah.
Just a big ECMO question mark sticker right on the side of the Lucas.
Literally what they did in LA.
Yeah.
It says "Got ECMO question mark."
That's awesome.
On the Lucas.
Absolutely amazing.
Yeah.
But to get back to your your original question about, is this just the inner ring departments, of course, which it is. The ones that are already do it know about it through training, like Frank's provided. But the protocol just has one little tiny bullet point about, and it really just says, basically
and nor can you find it in the protocol if you went to just search for ECMO. It's
correct. It's literally a key point down the bottom, and it basically says, yeah, you can follow that if you know what we're talking about, right? And then introducing another center in Cleveland in a regional perspective gives us the oomph now to say, well, we probably should do a formalized protocol. So
maybe we should get a box.
Getting back to
on that sheet. I don't know.
Yeah,
you're gonna get a circle. Get a whole sheet. I think we get a whole sheet, right? But
there's nothing.
Going back to that being top of going back to that being top of mind, right? Now that we are going to have a multi-center system or multi-center city, it deserves a place on that, right? And now that, of course, is going to be a little easier to bring to top of mind, because now we've got some more so than just a sticker that it's like, hey,
and I think for the
thinking about this.
the listening audience that are medics out there, or even basics and intermediates, there's really nothing different we need to do other than establish the fact that
Not
this
at all.
is an echo case maybe for you and get it to you. So I don't
Absolutely.
think there's any subset of trainings that you're giving other than this is what you need to look for.
Yeah.
So I think everybody can take a breath. We're not cannulating, you are.
Right. Yeah, absolutely. And that's
Not yet.
Not yet.
And that's part of what I stress too, is like you are still doing exactly the care that you're doing,
Yeah.
right? You are just mobilizing earlier and trying to identify these patients to call in, right? We're still going to shock them. You're still going to continue shocking them. You're still going to do amnio. Like if you convert them and get a pulse back, you did the job, right?
Yeah.
Fantastic.
And that person
Great.
we know shouldn't go on ECMO. Right. We've actually know from one of the clinical trials that came out equivocally between the ECPR and conventional arm. When you involve people that were randomized to ECPR and then got ROSC, they do better than if the folks who had to then get ECMO. Right. So there's still like a
Makes sense,
place
yeah.
for that, right?
Sure.
We don't want to inject iatrogenesis, inject morbidity and mortality by an ECMO run on someone that you get ROSC. So there's still a place for, the blocking and tackling of pre-hospital cardiac arrest in these folks. Because if you get ROSC, hey, hands off, they're going to do better than, the people that eventually will need ECPR.
Have to put
Absolutely,
up on,
yeah.
yeah.